Full thickness macular hole secondary to sub-ILM bleed in leukemia, an intraoperative escapade. A 14-year-old girl, known case of acute myeloid leukemia on chemotherapy, presented with diminution of vision in her left eye since 3 months. There was no history of trauma, lifting heavy weights, or any Valsalva-like maneuver. The right eye was essentially normal with a visual acuity of 6/6. The left eye had a vision of hand movement close to face, a normal anterior segment, and posterior segment revealed grey vitreous hemorrhage with an attached retina on ultrasound. The patient was planned for surgery. 325 gauge pars plana ports were made. Pore vitrectomy was done at settings of 5000 cut rate per minute and 350 mm mercury vacuum. After clearing a vitreous hemorrhage, a macular hole was noted. Microscope integrated OCT showed a large macular hole, more than 1000 microns, with nearly flat edges of the hole and a thin sheet of hyaloid overlying the macular hole. Triamcinolone acetonide was injected to stain the vitreous. There was a thin, taut, transparent sheet over the macula, which was quite tenacious and difficult to remove with the multiple attempts using a vitrectomy cutter. .025% brilliant blue-green dye was then injected. We noted that the residual sheet was not hyaloid and in fact it was the internal limiting membrane, and the area of ILM detachment with sub-ILM altered bleed could be easily demarcated now. ILM peeling was difficult beyond the edges of the detached ILM. A free flap of ILM was then taken from along the inferior arcade and stuffed into the large macular hole using a diamond-dusted membrane scraper. Position of the flap was then confirmed on the microscope-integrated OCT. The ILM flap was seen to be fully covering the macular hole. PFCL bubble was then injected over the macular hole to keep the flap in position, and it was again confirmed on MI-OCT scan. 360-degree scleral depression was done to rule out any peripheral break. Careful and gentle exchange of PFCL was done with air while maintaining the ILM flap in the position. (14% C3F8 gas tamponade was given at the end of the procedure. The ports were then sutured. At 3 weeks post-op, there was 40% gas in the eye and the OCT showed a type 1 closure of the hole. The visual acuity had improved to 1/60. At 2 months, the visual acuity had improved to 6/60 with good anatomical closure of the macular hole. There are few reports of macular hole formation with subretinal hemorrhage in cases of ruptured retinal artery macroaneurysm. Although the exact mechanism is unclear, increased pressure in the sub-ILM or subretinal space leads to retinal degeneration and subsequent hole formation. We propose that long-standing sub-ILM bleed led to the formation of macular hole in our case.